Okay, good morning, everybody, and welcome to our 30-second epilepsy surgery techniques webinar. We've got a great topic for today and two distinguished speakers. We're going to talk about what to do in patients who have dominant temporal lobe epilepsy with a normal MRI scan, dominant mesial temporal in particular with normal MRI. We've got two, as I said, outstanding speakers. Carrie Mew is with us from Westchester Medical Center in New York. And then she's going to start off and overview the topic and options and focus on responsive neurostimulation. And then Arthur Kukiert is going to present us a case to whet all of our intellectual appetites on this Sunday. So, Carrie, without further ado, welcome.
Great. Hi. I will share my screen. So I will talk today about using RNS for temporal lobe epilepsy, especially for patients with normal MRI. Disclosures, consultant for some companies that are not related to this, and I will discuss off-label uses of RNS. So I want to go into an overview of what the RNS system is. Since there's an international audience, I assume a lot of you haven't yet used or necessarily seen the RNS, so I'll describe what that really is and how it works. Use of RNS in temporal lobe epilepsy, ways we work up temporal lobe epilepsy with a normal MRI if we're thinking about placing an RNS, and then some of the techniques of where to choose to place your electrodes, and then combining RNS with other options. So the responsive neurostimulator is a closed loop stimulation, which is what makes it different from DBS, which I think people are probably more familiar with. So it continuously monitors the EEG. When it senses the seizure, it stimulates to disrupt the seizure. It's currently approved in the US for seizures that are focal seizures for patients over 18 years old, but it is often used off-label for generalized onset or for younger patients. It is something we always tell patients is palliative, not curative. There are definitely some patients where it is curative, but the majority of patients, it decreases seizures, but does not entirely stop them. So the closed loop modulation relies on feedback from the system. The neurologists program it to detect patient-specific seizure patterns. So it's nice because it's really personalized and it has a lot less stimulation during the day. It only averages about 6 minutes of targeted stimulation per day versus something like a VNS or DBS, which are open loop or stimulating all the time, and you'll get hours of stimulation. It really only fires when it sees what the neurologist has said is a seizure for that particular patient. It has an ECOG reading 24/7. The patient and the family are given a laptop, a wand, and a magnet. The wand, you can see in that picture up there, patient holds against their head right on top of the device. They download information to their laptop every day. They send that information weekly to the neurologist. And all the data is stored in what's called the PDMS, or Patient Data Management System. The neurologists are able to see that PDMS data and reprogram it as needed to gain better control. These are just a few examples of what the PDMS looks like. And please, at any point in time, let me know if there's any questions. In these pictures in box A, you can see a seizure happening in a patient who has left hippocampal depth electrodes, which are seen in the top two channels, and lateral posterior temporal subdural strip, which is seen in those two bottom channels. And you can see that the seizure starts, and each of the vertical lines is where the device fires in response. In box C, it's a close-up of a 10-second window to see where that seizure starts, which is between seconds 25 and 26. And you can really see it starting in channels 3 and 4. A2 is the little blue box there, which labels when the device recognizes that seizure. And it marks, each of these lines marks where the device stimulates. Later in the seizure, you can see that it then spreads up to channels 1 and 2 into the anterior hippocampus. So the nice thing about the PDMS is you can really see exactly what's happening in the brain prior to and during the onset of the seizure and how the seizure spreads over time. This bottom histogram is not from that same patient, but this bottom histogram shows you an activity graph of the long episodes. Long episodes are what the RNS records as essentially being likely an electroclinical seizure. Each one of the green lines is the number of long episodes per day, and then the blue line across them is a 28-day running average of the long episodes. So you can see it start to decrease over time. When you have temporal lobe epilepsy with a normal MRI, that occurs in about 30% of patients who have temporal lobe epilepsy. But having a normal MRI does not preclude RNS placement. It just means we need more evaluation. Just like you would do if you're considering a temporal lobectomy for a patient, you'll get other imaging. There are a number of studies that show if your PET is positive, patients could do just as well as if the MRI is positive. For us, though, oftentimes we'll end up going to intracranial monitoring or SEEG, and that's really the most common thing we'll do if we're considering RNS in a patient with a normal MRI and suspected temporal lobe epilepsy. And if the SEEG shows ictal onset, then we'll generally progress to the RNS, either mesial or lateral, even if the MRI is normal. And there are a number of studies that show that that's a very valid work through. This one, for instance, looked at 18 patients with MRI negative, non-lesional temporal lobe epilepsy with normal memory function. And they were able to show that you do get ictal SEEG abnormalities in the temporal lobe in 17, or interictal in 17 patients. The seizure onset was exclusively from the mesial structures in 72% of them, exclusively from lateral in 11% of them. Overall, it showed that, and other studies have shown as well, extratemporal seizure onset is rare if the video EEG, scalp EEG, semiology, everything is consistent with temporal lobe epilepsy, even with a normal MRI. So these are patients that we'll investigate with SEEG. We'll make sure that we put multiple SEEG electrodes in throughout the temporal lobe, making sure we get the amygdala, and then working our way back through the temporal lobe to make sure that we get several of them throughout the hippocampus. We'll also often place a longitudinal through the hippocampus in order to make sure we get very good coverage of it if we can't get really good coverage from the lateral aspect. It's also very common if someone has a normal MRI that we'll place bilateral SEEG electrodes. If everything suggests unilateral, we may only put a couple on the contralateral side, but it can often be difficult to tell bilateral versus unilateral with a totally normal MRI. So usually we'll end up placing at least a few electrodes on the contralateral side to verify for sure that the seizure onset is unilateral. There are some places, our center is not looking at this yet, but there are some places that are actually looking at ictal rhythm with normal MRI to see if theta versus delta rhythm at onset of the seizure can help predict temporal lobe epilepsy. And so this is something I think more places are going to start using. But for us, we usually rely on SEEG if it's a normal MR. If you decide you're going to use RNS for temporal lobe epilepsy, there's sort of a few different patterns of temporal lobe epilepsy that we'll cover. There's the mesial temporal patients, whether it's bilateral or dominant unilateral, meaning they're not a good laser ablation patient because it's eloquent cortex. Or if it's lateral temporal lobe and we think it's in neocortical eloquent cortex. Or if we think they have both temporal lobe epilepsy and seizures potentially starting elsewhere, then we'll consider corticothalamic or other regional coverage. The nice thing about RNS with temporal lobe epilepsy, a few different nice things about it is one, you can place multiple electrodes. So you have sort of a backup plan. So basically 2 electrodes can plug into the RNS at a time. But it's very common that we will place 3 or 4 electrodes. 2 of them will be plugged into the RNS, and 2 of them will have a plastic cap over the end and just tucked into the scalp. This picture here on top, we connected the hippocampal electrode and we connected a posterior temporal electrode. Then we had 2 frontal electrodes, which were just, these are the ends of them. They're not plugged into the device. They're just tucked under the scalp to give us a plan B. So if our initial plan, what we think is good temporal lobe coverage, does not give us sufficient seizure control, you then have sort of a backup plan where you can do a simple scalp surgery to unplug the ones that are in, plug in other electrodes, and not have to do a full craniotomy, not have to do a full surgery, a larger surgery again for them. So it does give you sort of options for the future. It also doesn't preclude other options down the road, and I'll talk in a minute about patients where you can actually end up getting enough data that end up moving on to a resection. And it really collects a lot of information that will inform future therapies. So whether you're talking about doing just a lateral temporal coverage, bilateral hippocampal coverage, any sort of temporal coverage with an RNS, you can end up using that data to inform future therapies. So the way that these are placed, you're going to use some sort of stereotaxis to place your depths first. I always do ROSA, and I always do the depths before I do any sort of craniotomy or subdural strips, just in case there's any shift, any bleeding, anything like that. I want to make sure my depths are accurate. So if I'm doing bilateral hippocampal or even unilateral hippocampal or thalamic, which we'll get to, we'll place those first. Again, more than 2 can be placed at once. Only 2 can be connected and usable at any one time. In the image up here, you'll see this large plastic burr hole cover. They used to recommend that you use these big covers to hold down any depth electrodes in place. I actually find them kind of bulky and don't love the way they work or the way they fit. So for the last couple of years, you can actually just place the electrode in. There's a little plastic sheath that comes in the kit, slide it over to protect the electrode, and just screw it down with a regular plain old dog bone to the skull. It's very easy, doesn't take up a lot of space, allows you to use a tiny little burr hole instead of a large burr hole to place the electrode. And it makes it easier if you have to come back to change anything because you don't have a large plastic cover in your way. I always try to avoid having the electrodes pass directly under the incision. I don't want to have risk of potentially infection by having electrodes go under the opening. And when you come back in to change the battery at some point down the road, I don't like opening up the skin over electrodes. So I always try to make sure that my depth electrodes come this way to the cranie so that they're not passing under the electrode. After you place your depth electrodes and any subdural strips you're going to place, the last step is to do the craniectomy for the generator. You place this little metal tray called a ferrule inside of your craniectomy site, and then the generator just pops into that ferrule. That way, whenever you have to change the generator, it just pops out and pops back in and screws down with one screw. You do that last because once you have the battery up, you can't use cautery anymore or you'll short out the device. So you make sure that you get good hemostasis and you've done the other parts of the surgery before you put the generator in. When I'm planning it out, you have this little template you can hold up to the skin to decide exactly where to put your craniotomy. Once you've put it in place, you test it, you test any extra electrodes that are in there, you make sure the ones that are connected in are working well, and that you talk to the neurologist to make sure everyone knows exactly what's connected into which port. Usually I keep patients in the hospital for a couple nights after surgery for IV antibiotics. Most of my patients are pediatric and most of them are developmentally delayed. So I usually keep them in the hospital for a couple days of IV antibiotics and to make sure that they're not going to pick at or scratch at the incision before we let them go. So the steps basically, in our hospital, we use a O-arm. This is an article I found online that had nice pictures. You're going to do your ROSA or your other planning, position the patient and figure out exactly where you're going to put your craniotomy using the RNS template, the ferrule template as a guide. You're going to place your leads. If you can do them all through that same site, that's nice. If you're doing contralateral, then you'll just make sure you tunnel them across. After you place all of your leads, you do the craniotomy, secure the ferrule tray in place, and then you pop in the generator and connect it to the leads. Like we said, there's a few different types of temporal lobe epilepsy that you'll treat with RNS. There's mesial temporal, neocortical, and then temporal plus other sites. Mesial temporal RNS patients tend to do very well. This is a study looking at adult patients with mesial temporal lobe epilepsy treated with RNS. There was a 70% median seizure reduction at last observation carried forward with an average of 6 years of follow-up. 29% had at least one seizure-free period of 6 months, 15% had at least one seizure-free period of a year. And there was no difference in seizure reduction statistically for patients with and without mesial temporal sclerosis. So even if they had a normal MRI, they still did well. In fact, in this particular study, it was not statistically significant, but there was actually a higher responder rate in those who did not have mesial temporal sclerosis, although statistically it was equal. but there was no significant difference between those who had mesial temporal sclerosis and those who don't. So even with a normal MRI, RNS can be very effective for patients with mesial temporal onset. Even for neocortical patients, again, another study looking at RNS with neocortical onset. Of the lateral temporal patients in this category, the median reduction in seizures was 58%, and there was a 67% responder rate. And again, a lot of these patients did not have any lesions on imaging. And again, there was no real statistical difference in patients who had abnormal MRIs versus not, although there was a 77% reduction in seizures for those with lesions in MRI, 45% reduction in those with normal MRI, but it was not statistically different. If you have a region you want to stimulate, so if you've got temporal lobe epilepsy and other places, or if you have a large region of temporal onset, then you can either do regional neocortical stimulation or cortical thalamic stimulation. So if you have, for instance, a large neocortical onset, it goes superior temporal as well as other areas. You don't necessarily have to have your electrodes directly in or on the target itself. You can flank the target and get regional stimulation. You can be at least a centimeter apart, and you can get good control. And this study, for instance, has 75% median seizure reduction, even with the electrodes placed a distance apart, flanking that area. Here, for instance, you can have two temporal electrodes, subdural strips, place them a centimeter apart, and you can actually get regional coverage. So even if you're not exactly on the spot of seizure onset, you can still get good control with RNS. If you have a larger area than that, if it's both temporal seizures and generalized onset or seizures coming from other places, then we actually often will do cortical thalamic stimulation, and you can still get good seizure reduction even with cortical thalamic or even sometimes bilateral thalamic stimulation for temporal lobe epilepsy. The three main nuclei that are studied are ANT, CM, and pulvinar. For temporal lobe epilepsy, ANT and pulvinar are really the two main targets. The ANT is sort of more commonly targeted for mesial temporal epilepsy or limbic circuits, but pulvinar actually is also being studied, especially for posterior temporal lobe epilepsies, or also possibly for mesial temporal lobe epilepsies as well, but we still need a lot more data on it. There were a couple of different studies looking at ANT stimulation versus RNS at the temporal lobe. This particular one looked at DBS at ANT, and it really showed that there was not a huge difference. DBS ANT patients had a 60% seizure reduction, whereas temporal lobe RNS patients had a 70% seizure reduction. And there are starting to become more studies looking at ANT RNS versus temporal lobe patients, where there's no really good controlled study for those two yet. Other studies looking at transient stimulation via SEEG electrodes. We haven't done that, but I know it's commonly done in France, where they'll actually stimulate through the SEEG electrodes, and they were actually able to see that the pulvinar stimulation evoked potential response rates of up to 80% in mesial temporal, 76% in temporal neocortex. So there's actually a lot of data that shows that thalamic stimulation can have benefits for temporal lobe epilepsy. There actually have been studies also looking at when you're placing your SEEG electrodes, you can place those electrodes into the thalamus and help determine which nucleus might be most beneficial for your patient. So this was a study looking at monitoring ANT, medial dorsal, and or pulvinar for patients with temporal lobe epilepsy who are undergoing SEEG. They looked at multiple thalamic nuclei, and they were actually able to stimulate single pulse electrical stimulation at the seizure onset zones and seeing how they were showing up in the thalamus. And in more than half the patients, the pulvinar was actually involved earlier and more prominently than the ANT, but pulvinar and ANT were both very often involved and both showed up very quickly at seizure onset. And so these are both areas that are really things we should consider for temporal lobe epilepsy patients, even those with a normal imaging. Since I do mostly peds, I just wanted to quickly throw in that this is actually useful for pediatric patients as well. For patients with RNS, patients who had temporal seizure onset had a 50% seizure reduction, so it works well in pediatric, not just adult patients. The nice things about RNS and temporal lobe epilepsy is that even if you don't think a patient is going to be a resection candidate, so you're thinking you're going to need to use RNS because you can't take out that tissue, it's eloquent tissue, it's bilateral, some reason why you can't resect it, the RNS may actually show you that they are a resection candidate down the road. This was one initial study of the patients who were in the NeuroPace RNS trial. They looked at 11 patients who were not getting sufficient benefit from the RNS. 5 of them were determined to be resective candidates based on RNS data. 2 of those were temporal onset patients, and they actually all became seizure-free. 2 of them still had the RNS in place, so oftentimes you'll leave the RNS in place even if you do a resection. This was another more recent study, 157 patients with bilateral hippocampal RNS leads placed because it was felt that they had bilateral temporal lobe epilepsy, therefore you can't resect anything. However, 25 patients, 16% of them were found to have mostly or entirely unilateral seizures. 9 of them were entirely unilateral per their RNS data after a couple of years of monitoring. 15 of them were bilateral, but were almost entirely one side. So these patients were then taken for a temporal lobectomy, generally leaving the RNS in place, just pulling it back. So that you can see here that they did a temporal lobectomy and pulled back the electrode on that side, left the one on the contralateral side in place. And of those who were entirely unilateral, all 9 were seizure-free after resection. And of the 15 patients with bilateral seizures, 8 of them were seizure-free, but they all had a significant reduction in seizures. So the nice thing about RNS is it doesn't preclude you from doing a resection later and can actually show you patients potentially who are seizure candidates who you didn't think were ahead of time. You can also combine RNS with resection. If you have what you think is bilateral temporal onset, and one side you know is clearly the dominant side for that patient, you can resect the non-dominant temporal lobe and then put RNS electrodes into the dominant one. Or if you know it's unilateral, but it seems to be larger than just mesial, it seems to be including neocortex, you can do a resection of the anterior temporal tip and then put RNS strips on the eloquent cortex more posteriorly. You can combine RNS with VNS. So if you have temporal lobe patients who have a VNS in place already, it is safe to use both at once. And there's no device-device interactions, no reason why you can't place both in patients. In fact, they may actually be synergistic. There's a couple of case reports that show that when the VNS was turned off, they had actually an increase in seizures, and having the two together worked better than either device alone. Neuropsychological improvement occurs with RNS in patients who have either mesial temporal onset or neocortical onset. You can get improvement in verbal learning for patients with mesial temporal onset and improvement in naming for patients with neocortical onset after the RNS is placed. Quality of life also seems to improve. In 41% of patients with mesial temporal onset, 51% of patients with neocortical onset reported improvement in quality of life. A small percentage did unfortunately report a decline, but the majority, or a larger percentage, were in improvement. And SUDEP risk seems to decrease with RNS. In the average population of patients with epilepsy, SUDEP is very rare. However, in patients who are considered for epilepsy surgery, those with significant drug-resistant epilepsy, the rates are between 6 and 9 per 1,000 patient years. With the RNS in place, it brings it down to about 2 per 1,000 patient years. So there's still a lot that we need to know before we can start recommending RNS for everyone with temporal lobe epilepsy. We need to know who are the optimal patients. Is it different for MI-negative patients? It doesn't seem to be if you do an SEEG, but do you really need the SEEG, or can other data, such as your scalp EEGs, help predict who will benefit from an RNS? When should you combine it with resection versus placing bilateral RNS or RNS alone. And then exactly what do you target? We still sort of debate patient by patient with our neurologists and at our conferences when we should do depth electrode, when we should do a hippocampal electrode with a subtemporal strip, when we should do cortical thalamic. And there's still a lot of debate with that for each patient. And then the stimulation parameters in terms of how it changes over time, and how do you know if you should continue to make changes. So that's sort of just an overview of using RNS for temporal lobe patients. Are there any questions or things I can sort of explain better for anyone?
Why don't we go ahead and have Arthur present and discuss, and then I think there'll be plenty of room for questions. Oftentimes people will put questions into the chat, and I'm sure that plenty of people in the group here will have questions too. So, because obviously, as you raised at the end, there's a lot of questions to be raised. Just one quick question you didn't mention. So, advances in MRI compatibility.
So you can do an MRI with RNS in place. It's MR conditional. So you have to make sure you have a send receive coil, and you just have to verify that the techs know that the RNS is there. And there is an MRI setting, so you can essentially turn the device off during the scan. But it is MR conditional. It does lead to an artifact around the generator. The leads don't have a huge artifact, but the generator does. So there have been times in patients, if we're planning to place new electrodes, for instance, if they have a depth in a subcortical, like in the hippocampus and the subtemporal region, and now we want to put thalamic electrodes in, there are times when I'll actually take out the generator in order to get a better quality MRI so that I can then target the thalamus accurately without having all the artifact. But you can get an MRI with the device in place.
Yeah, and we have many participants here, so if people have questions specifically about RNS, if you could put them into the Q&A section, we'll try to get to them as we move along. So our next speaker needs no introduction. It's Professor Kukiert from Brazil, who's been one of the original thought-provoking leaders in this epilepsy surgery technique space. And every time we can't find a speaker, we pull Arthur in at the last minute because he's got a great talk on about everything. So one of the things he's really actually world renowned for is his experience with neuromodulation, and particularly deep brain stimulation for various conditions. So he's going to talk to us now about surgical treatment and present a case for us.
Can you see my presentation?
Yeah.
You could. Okay. So thank you so much for the kind introduction, Guy. I'll try to give an overview specifically related to dominant temporal lobe epilepsy with normal MRI. And at the end, I'll present a case so we could discuss. As you mentioned, I guess there are lots of things to discuss. So these are the competing procedures for treating temporal lobe epilepsy. So it's a kind of a big menu, and our role here is to try to assign each type of the procedure to each type of patient, which is obviously not easy, not always easy at least, but you see some resective, some ablative, and some neuromodulation options. I will try to go over. So just for you to get an idea of our own bias, because I think everybody has their own bias. This is what we published on temporal lobe epilepsy and normal MRI like 15 years ago. Just pay attention to group 1, which is the dominant normal MRI temporal lobe patients. And you are going to see that as far as it relates to seizures, outcome was pretty good and pretty much compatible with the other resective procedure. By that time, we were offering resective procedures for this kind of patients. So our results are pretty good in terms of outcome related to seizures, but the problem was cognitive outcome with these patients. All these patients who had either normal or partially abnormal verbal memory decline. So, and this is not a majority, is 100%. So from that evaluation on, you can imagine that our bias went towards non-resective procedures in these patient populations, meaning the patients with dominant temporal lobe epilepsy and normal MRI. Just to mention that there are other procedures that try to approach this issue of cognitive decline, but still doing some kind of resection or disconnection. One is multiple hippocampal transections. This is more the major series on hippocampal transection came from Japan, and they reported that they got a fairly good seizure outcome, not as good as in a conventional corticoamygdala hippocampectomy, but that this cognitive decline was much lower by using hippocampal transection instead of hippocampal resection. So this would be one of the procedures that you could think about when trying to avoid cognitive decline after dominant temporal lobe resection. The other is temporal lobe resection sparing the mesial structures. You have two big series on that, one coming from the Maudsley in England and the other coming from Montreal, Findel series. It's basically corticoamygdalotomy. And this was supposed to reduce cognitive decline in these preserved patients with dominant temporal lobe epilepsy. But in fact, although in the same way as the hippocampal transection, many of these patients got verbal memory decline, even if you preserve the whole hippocampus, and meaning that probably the entorhinal mesial cortex and even the temporal pole might have some relation to verbal memory. But these are the two procedures that you can consider trying to spare the hippocampal function and verbal memory. Other than that, more recently have the introduction of LIT in clinical practice, and LIT is supposed to give you the same seizure outcome with less cognitive effect. And this is true that it's a good option for seizure control, but seizure control, you already know that's not as high as in conventional corticoamygdala hippocampectomy. And it appears that from a cognitive point of view, you can have a better results with LIT than if you do microsurgical hippocampectomy, which makes sense because in LIT you always have some islands of connective hippocampal tissue. So you can in the same way as in transection or sparing the hippocampus, you can guess that you might have a better outcome in terms of cognition, but then you have kind of a worse result, not worse, but it's not as good as in conventional corticoamygdala hippocampectomy. And here comes the patient preference. Many patients would prefer, let's call it a less invasive procedure versus a traditional craniotomy, even if they know that the result would be worse or slightly worse than the conventional technique. Not just to remind you that LIT came after radiofrequency amygdala hippocampectomy, and one of the major manuscripts regarding radiofrequency amygdala hippocampectomy came from the Czech Republic. This is much earlier than LIT. Most of the authors performing LIT usually initially use this kind of cohort to guide how they would do it. And radiofrequency amygdala hippocampectomy is as effective as LIT amygdala hippocampectomy. Is probably not as much as technological advance. You don't have any control. You don't use MR tomography, but the clinical results are about the same as far as you can read from the manuscripts. So this turns us to our bias on neuromodulation for these people with dominant temporal lobe epilepsy with normal MRI, who usually have preserved verbal memory or slightly damage verbal memory. So this is not the kind of people as you see in dominant mesial temporal sclerosis, where you have these people in mesial temporal sclerosis will have a 2 standard deviation deficit in verbal memory, and this is not what you're going to see in these patients with normal MRI. So neuropsychology is probably one of the most relevant evaluations in this patient population. So talking about neuromodulation, let me just go quickly over the available techniques. The older one being VNS. It's very difficult, despite there are more than 150,000 people implanted with VNS. It's very difficult to pull out who are the best candidates. And for temporal lobe epilepsy, as you can see, is probably one of the worst results of VNS. There is a result from VNS, but maybe something like 25% of the patients, and if you as responders, and if you look as the seizure-free patients, you're gonna see that, and then you have to resort to meta-analysis and systematic reviews, because there are no manuscript addressing directly this kind of information. So, but if you look into a meta-analysis, you're going to see that 7 to 8% of the patients using VNS for temporal lobe epilepsy will get seizure-free. And then the other competing with the neuromodulation technique, the ANT-DBS. ANT, as you know, is part of the PAPE secretary, and it's intrinsically connected to the temporal lobe. So it does mean that you are going to be getting indirect hippocampal stimulation by using ANT stimulation. And if you get a look on the outcome after 5 years, you have something like 70% of responders and 16% of the patients are seizure-free. It's almost the double of what you get by using VNS in this patient population. And if you go even a longer follow-up, the results are pretty much stable. So it's around 70% of responders, meaning at least 50% of seizure frequency reduction, and 16% of patients seizure-free for at least a year by using ANT-DBS. Then come RNS. I'm not going to discuss much of this because Carrie did such a wonderful job, but if you go and have a look on long-term follow-up for temporal lobe epilepsy, you're going to see a seizure reduction, a mean seizure reduction of 70%, meaning 66% is almost 70% too, and seizure-free patients for at least a year of 15%. And these numbers are remarkably similar to what you just saw for patients using ANT-DBS. So it's different technology, but the results are pretty much the same. And of course, these results are also stable, as I mentioned, for ANT-DBS. So after a very prolonged follow-up, you can expect 75% of responders and around 18% of patients being seizure-free, especially if you look at the mesotemporal lobe cases. And real-world experience, meaning uncontrolled protocols, gives you about the same data than in the control studies. So you have for RNS responders for 84%, seizure-free 18%. So for both ANT-DBS and RNS, the results are out there. They are stable and they are very similar. These are the initial 2 pivotal studies I just mentioned for ANT and responsive neurostimulation. You see that this is the control, the blinded phase of each of the studies, and the format of the curves are pretty much similar. They're very similar outcome regarding this patient population. And the last neuromodulation option is hippocampal DBS. It was pioneered by Velasquez in Mexico City by the early 21st century. And we started doing this in an open series of 9 patients, 4 of whom became seizure-free. And this optimism led us to develop a control study, a blinded, double-blind control study in patients who were not considered candidates for resective surgery for any reasons. That could be memory deficit risk, is the usual issue in dominant temporal lobe epilepsy, a bad temporal seizure onset, and there are patients who are not willing to undergo craniotomy, but this were the minority, and we use a posterior entry approach and use an electrode through the long axis of the hippocampus, and we could target from the head to the posterior body, and the tail was left out because the tail curves medial and not superior. You cannot get it in a single entry. And this is the type of post-op MRI that you get. The black dot inside the hippocampus are the contacts, and you see the trajectory there. This is then led, as I mentioned, to double-blind controlled studies using hippocampal DBS. We've got a longer blinded phase, which was useful because in both ANT and responsive neuromodulation studies, the blinded phase was only 3 months, and they were significant only by the third. So they probably missed effectiveness after the third month. We are very effective in terms of seizure frequency reduction. Contrary to many other neuromodulation techniques, hippocampal DBS can offer seizure control over the first month after full stimulation, and is especially active in focal impaired aware seizures. It is effective in focal aware seizures, but as you see, focal aware seizures seems to be more resistant to seizure control with stimulation, which is also true for a resection, because sometimes you do a resection and the patient remain with some auras. This focal aware seizure, they seem to be more resistant to everything. And if you put the 3 blinded, double-blind studies together, you're going to see that hippocampal DBS appear to offer earlier and more robust seizure control than both ANT and responsive neuromodulation. I guess you're kind of confused about the data, but this is the long-term effect of the hippocampal DBS, and again, you see that it's much more effective in focal impaired awareness seizure than in focal aware seizure. But it's not that it's not effective in focal aware, but it's less effective than focal impaired. And just to summarize the effect of the different temporal lobe, the neuromodulation techniques in temporal lobe epilepsy, this is what we got in terms of responders and seizure-free rates. Of course, I guess it's VNS is probably the worst one in terms of both percentage of responders and seizure-free patients, as you can see. So this being said, I brought a case that I hope will generate some discussion, and I just want to proceed. Would that be okay, Guy, if I proceed with the case?
Yeah, please, go ahead.
Okay, so he is a 16-year-old boy, right-handed. Seizures begin by the age of 12. They were initially 1 seizure per month, and that increased over time, and he had daily seizures by the time we saw him. He had focal aware seizures characterized by ascending epigastric sensation and tachycardia, and he did have focal impaired awareness seizures, which basically consists of motionless staring and a 20-second of post-ictal aphasia. It's nice to present these cases because you don't have to show any MRI, because MRI was normal and PET was normal. And this is not so rare in the clinic. So this is the type of patient you're gonna, it's not very often, but you're gonna see them. His video EEG recording showed that interictally very frequent left anterior temporal lobe discharges by F7. His ictal recordings were very clearly left anterior temporal by F7, and he did have ictal tachycardia, and heart rate ranged from 82 to 126 almost every seizure. And his neuropsychological finding toward he is a very well high functioning boy. General IQ is 136. This is, well, I guess very high for the standards, and verbal IQ was 138 and performance IQ 132 and absolutely no memory deficit. So this is his interictal EEG. You can see very clearly well-defined spiking at F7. These were very frequent. There's no, we were not able to record any spike or any abnormal activity over the right temporal lobe or actually over the right hemisphere. It's just this at F7. MRI was reviewed as many times as you want. So, and he got 3 MRIs, 2 of them 3T. It's really, the review in by many people, it's really normal MRI. And this is his interictus. And this is his ictus. It's very clearly coming from, again, the same lead. It's F7 is very clearly a left temporal lobe onset. I won't show you the movie because it's basically motionless stare. So it's there's nothing specifically useful to show you. So, and then it comes to further evaluation. And then maybe we could stop and we could start discussing if would there be any further evaluation that you would suggest, that you feel mandatory, or you don't need any other evaluation? What do you think about this boy?
I don't know if any of the attendees want to speak up, but I know for us, we would probably go on to a stereo EEG. Even if we know it's left temporal, we don't know for sure if it's mesial or lateral or how far back in the temporal lobe it goes and all that. If it's a dominant temporal lobe, we probably wouldn't want to resect necessarily. Potentially we would do grids if we thought something was very focal and potentially resectable, but more often we would do stereo EEG to sort of see where it's coming from.
If so, you are what kind of targets for SEG?
Throughout the left temporal. So amygdala, multiple back in the hippocampus, parietotemporal, and then usually some like an insular or something that can end up mimicking, maybe an orbitofrontal, something that can end up looking temporal, just to verify that it is temporal and then to see exactly where within the temporal lobe it is. Guy, I don't know if you would.
Yeah, Carrie, I was going to ask you, you brought up the topic in your talk about during an SEEG of thalamic sampling, are you all routinely sampling the thalamus? And in a case like this, where would you sample?
We're not doing it routinely. It's something we've discussed for most patients, but oftentimes we feel like we'll be able to do a temporal, like a focal RNS lead if we're going to do that. So we don't do it all the time. But if we were going to, we'd probably do ANT and or pulvinar. If it looked like it was more of a posterior temporal onset, then we'll do pulvinar. If it's more of an anterior or sort of what we think is probably mesial temporal, even with a normal scan, then we'd probably do ANT. Some places will routinely do both. We haven't started doing that routinely yet, but it is something we're discussing more and more with each patient.
Yeah, Arthur, I think it's interesting, you know, that with the expansion so much over the last 5 to 10 years of stereo EEG, like this case you're presenting, I think in sort of the predominant grid North American era, you know, most people would probably move towards something neuromodulatory initially, given the super high function, and not go through a craniotomy for a grid. Whereas I think there's a lot of people who now would consider stereo EEG exploration to be certain that there's not, you know, a focal subtle dysplasia somewhere that we're just not picking up on MRI, or because you have a very, very strong EEG in this case, right?
Yeah. Maybe Christian and Bertu would like to join and help.
I think we would certainly consider SEG in this case. We do very few strips and grids, and strips in the temporal are more for sometimes for lateralizing if you cannot do SEG, but I think that is not relevant in this situation. So we would certainly go for SEG if the patient would be interested of resective surgery. We don't do, hippocampal stimulation, but SEG would definitely be considered.
Yeah, we also would do SEG, and I think we would do it exactly the same way as Carrie had just described it in terms of targeting. We're not doing thalamic recordings yet, but probably we should start this as well. And we would do an fMRI just because we have it, and our radiologist is very experienced with it. Ictal SPECT is something we do sometimes, but it's let's say very challenging to get the good ictal SPECT. I don't think we would do a VADA test. We don't have MEG, no source imaging. Yeah.
I think also we would not consider ictal SPECT because it doesn't give so much further in this case. The resolution is quite low, and we would certainly confirm with fMRI, but we have stopped VADA tests 15 years ago, and we don't do them anymore.
We do still routinely do WADA if we're thinking about resecting what we think might be dominant to verify. But if we're just thinking RNS, or if we're pretty sure it's got to be dominant, then we usually don't. But if we're not 100% sure it's dominant and we're thinking about resecting, then we will often do a WADA still. Our functional MRIs, I don't feel like I don't have as much confidence in the results of them, at least the ones here, as I do with the WADA.
So I guess, are we aiming on a cortical resection or neuromodulation for this patient? In the end.
If an SEEG were to show that it was just mesial temporal, anterior, just amygdala, something like that, then we would potentially do laser ablation based on the SEEG findings. If, however, it were to find that it was a large portion of the hippocampus, such to the point that I would be worried about dominant hippocampus, if it was neocortical, anything like that, or just a larger region within the temporal lobe, then we'd go to RNS.
Yeah, I think if SEG shows us mesial onset, then we would probably do a selective mesial resection. We haven't done lid for temporal lobe epilepsy so far, even though we have the lid available for 4 years or so, but we haven't used it for these specific cases. So still I would, if it's a lateral temporal and a very widespread seizure onset zone, we wouldn't go for a resective procedure, I think.
Almost the same as Christian. We don't do so much pure selective amygdala hippocampectomy, but we can certainly do restricted resections. So we would go on that line about.
Do you have any doubt that this is mesial temporal sclerosis as far as this focal aware seizure type?
You mean mesial temporal onset, not sclerosis?
Yeah. If mesial.
I think with the early tachycardia, you just want to be certain that it's not anterior insula involvement, and I mean you're going to get all that if you're doing a stereo EEG. But I think it's very likely, as you say, mesial temporal, but you still want to be certain he's 16 and super high functioning, right?
Yeah, because then you get to the something that Carrie has already started mentioning. If we need SEG for every single patient, or if this patient can go ahead without SEG.
With a normal MRI in a high functioning patient, we're much more likely to do SEG. If it's a lesional MRI, then we're more likely to skip it if the MRI lines up with semiology. But for a normal MRI, I think we'd be pretty hesitant to do any sort of resection without an SEEG to verify exactly where it's coming from.
That.
And any other tests that you feel would be interesting? Because I got the feeling that you are not, other than SEG, you are not interested in anything, right?
A WADA, if you don't know for sure if it's dominant. A WADA, if it tells you it's non-dominant, great, then you could just do a big resection.
Yeah, but how many right-handed people with normal MRI you saw having right hemisphere dominance for language?
Yeah, very rare. I think most of the time we would do an SEEG. For us, the ictal spect and MEG, we rarely get them, and they're not super useful most of the time.
I saw John.
I think if you could get it here, Arthur, I mean, we don't have a MEG, but we outsource MEGs. I think this would be an interesting case, actually, because of how active it is interictally. I think if I had the ability to get a MEG in this patient who's high functioning, I would do it. And I would not do a WADA, and I would do an fMRI and ictal spect. I think, as Bertel said, I'm plus minus.
I guess I saw someone raising his hand.
I think John or somebody, actually Laura Castana was saying fMRI SEEG with temporoinsular orbital electrodes.
Yeah, I think that's what we would do.
Yeah, I guess John raised his hand too, or
I think he was asking separate. He had a question about cognitive outcomes, which we can get to with other. Let's do your case first.
yeah. Okay, so then we come to our options, right? Since many of you would rely on SEG, suppose that SEG shows you it comes from the mesial temporal region. What kind of procedure would you offer this patient? It's very likely, SEG would very likely show that. So.
For us, we generally would do a laser ablation if we think it's mesial temporal. It's a nice small incision. It doesn't prevent you from going back to a larger temporal resection if you're not getting sufficient benefit. And patients tend to tolerate it very well.
Wait, I'm sorry, you would do a laser ablation in this high functioning 16-year-old in their dominant hippocampus?
We would do it. I mean, usually we'll end up, if we think we're going to do that, we'll usually do a WADA to see if we can safely. And a lot of people end up being bilaterally safe to do, but if it's unilateral and we think we can't, then we'll do an RNS electrode into it.
I saw that John immediately raised his hand, so.
Let me see if I can figure out on participants how to bring some people
There's
in.
an allow to talk button.
Yeah, it's okay. Well, let's do a.
Yeah, just bring him. Yeah. Okay, there he is. So John, please show yourself, and you can only speak after you show your face. So.
Can you see me or hear me?
Yes.
Yeah. Okay, good.
I immediately ran into my spacious bathroom because my children are screaming. But what I was going to say is just to clarify this issue of how WADA can or should be used. I think what's being referred to is using a standard WADA for determining language dominance. But remember that the standard WADA very often doesn't really anesthetize the hippocampus. So if your question is whether there's going to be a deficit to ablating the dominant hippocampus, at least in my previous group at Emory, we typically would go on to a selective WADA or a PCA WADA. And whether it's true or not, what we often found is patients that failed a standard WADA and then passed a selective WADA, we would go on to do a standard lit of the hippocampus in the dominant hemisphere, and none of those patients had a substantial or a catastrophic memory outcome. And that paper is probably going to be in press here soon. Dan Drain is the senior author, or the first author. But so the use of a selective WADA may help you better address what actually happens in the hippocampus. That said, most people aren't using WADAs to address these sorts of questions. Another previous paper, prospective, from Dan Drain and our group at Emory basically suggested that when we were doing hippocampal ablations in the dominant hemisphere, the verbal memory deficit was not as much as we would have expected. And here's where a guy usually says, yeah, but it can go down. But in that patient population group compared to open selectives, we did not see significant verbal memory deficits despite being dominant hippocampus. And the other point is often, just like on this list, lit is sort of assumed that when you say lit, you mean the way it's been presented in the first 10 years of its use, which is a single trajectory through the hippocampus. But lit is just a technique like any other, and you can actually use lit multiple trajectories, target multiple things to do the same thing you would do with a selective. I think a lot of our early experience of whether lit is effective or not has been colored by learning curves and how it was used, and the use of it is still evolving. So at least in our hands, we feel we can do just as good a job with lit as we would with an open selective. So to summarize, we have in the past used a selective WA to determine the potential safety in terms of memory for addressing hippocampal ablation. And then we often do multiple trajectories to get not just the hippocampus, but all of the uncus, as much of the pure form as we can reach, and also the entorhinal cortex, usually with at least 2 trajectories.
Thank you, John. Yeah, I definitely agree with that. And there are times when we've used an SEEG and found that it's, just amygdala, just very anterior tip, and then we'll actually follow that same trajectory for the laser ablation rather than doing a full hippocampal burn.
And that exact when RF is very helpful as well, because you can RF anything you're thinking might be part of your onset zone and use that as a test. And then, of course, you can always come back later for further lit or eventually a larger resection.
We definitely want to start doing RF. We haven't started doing that yet, but I absolutely want to do that for that exact purpose.
It's so interesting because right now we are very, very reluctant to offer any resective or ablative procedure in such a high functioning people. Are you sure you're going to be willing to do any type of ablation or a resection? For his IQ is 136. Huh?
Yeah, no, what I said is what you can do. Now, our neurologists, like the neurologists I'm working with now, are mostly adult neurologists, and they are very focused on ablating the onset zone and the worst outcomes that they would expect with neuromodulation. That doesn't necessarily mean I agree with that. And I do offer both options to patients, especially high functioning, especially if there's any ambiguity whatsoever about bilaterality for the reasons that have been mentioned. You can do RNS, you can monitor for a while, be absolutely convinced that that's the onset zone, and have a more prolonged discussion about whether they benefited sufficiently from the RNS, especially if in a 16-year-old, to get them to young adulthood or later. If they're not sufficiently satisfied with their outcome, you can always convert to a more ablative or resective strategy later. So I agree with you. My bias in a 16-year-old in this case would be more towards the neuromodulation strategy, but recognizing this is an ongoing discussion where we can always take more brain.
I completely agree that this is a really difficult, of course, it's a really difficult situation. And even if I said that there was a possibility, we would probably hesitate very much to do a resection. He's 16 years, he's going through high school, university, and further on. We have a long time ago had some patient with high functioning where the neurologist followed her and got it under control for later resection. You could sort of postpone it after high school and university studies. You should not forget that possibility, really.
And RNS has pretty good results. You can do a hippocampal depth, you can do a subtemporal strip, you could do an ANT or pulvinar electrode, and you can get very good results with RNS if you don't want to resect anything.
If you have it, yes.
By the time we've published that paper that I initially showed you at the beginning of my presentation, we have many patients that we told them, well, we are going to be highly going to be high probability of being seizure free, but your memory is going to get worse. And then he said, no, just go ahead. I want to get rid of the seizures. No problem. Let's go ahead. And they became seizure free. And now they are complaining for years of their memory. So I'm not sure that it is a good idea to either resect or lesion. That's our bias. I'm not sharing that this is the correct answer, but it's our bias based on our experience. And As a matter of fact, we don't think that SEEG is needed for every neuromodulation case. 50% of our patients submitted to DBS for epilepsy did not undergo SEEG, so we think there are some situations where you can skip SEEG, and we found that this one was one of them. We were pretty convinced that there was a mesio-temporal lobe onset of the seizures, and we went towards hippocampal DBS in this patient. And this is the approach. And as you can see, you can put the leads in the middle of the hippocampus. Our approach is a little bit the entry point is a little bit more mesio than you expect for a lead case, for instance. But in this way, you can get the whole hippocampus except for the tail.
Hey, Arthur, maybe you and Carrie could comment specifically on, so when you're doing a hippocampal DBS, are you doing it semi-sitting? Are you doing it prone? You're using a frame, presumably, you know, in terms of, so your workflow of the operation itself. And also in terms of, are you modifying where you're placing the pulse generator with a bilateral posterior entry?
Yeah, sure. We use a frame and we use a posterior entry in a prone position. It's very kind of a straightforward. If you do it bilaterally, you just have to, you're going to put the generator in the chest. So you have to just tunnel the extensions and just connect it to, but you have to turn the patient from prone to supine position and just connect the generator.
So do you leave the extent, you tunnel them as far down as you can from prone, and then you turn them over and go access them and tunnel them the rest of the way?
To be honest, in this position from the posterior, when you put the patient supine, it's like it's similar to a VP shunt, the position, and you don't need to tunnel them. So you just leave them. Well, you are going to put the generator on the right chest, so you have to tunnel the one from the left to the right. But instead of using two small incisions, we use a unified incision. So we have a single incision there, and we just put the cables all to the right and reposition the patient. It's almost like passing a VP shunt. It's a very similar position and situation.
Hey, Art, can I ask about neurocognitive outcomes in hippocampal DBS? If you're doing continuous hippocampal stimulation, the idea is to preserve neurocognitive outcomes, but does that have any impact on memory?
Yeah, that's a great question. We are just putting together the series, a series of 10 patients in whom we had pre and post adequate neuropsychological evaluations, which is kind of difficult for us because these people perform sometimes neuropsychological evaluation in different centers. And so it's not very homogeneous, but we got just the ones from our center. What I can say is that we've seen no worsen of memory functions in this kind of patients, especially in this one, since you already mentioned it. So I would just show you this. This is his his neuropsychology pre and post. As you can see, there was no decline in either general IQ or verbal IQ. It appears it's a little bit higher post-op, but I don't think this is significant. This is just showing you is that there was no memory decline in this patient, and as a group, I cannot give you the final numbers, but as a group, this is what you are going to be seeing. You don't have any worsen. Sometimes they seem to do better, especially if they got seizure-free. But the main issue is that they don't got that worse, including those being submitted to bilateral hippocampal stimulation. So I guess from a neuropsychological point of view, even though it's continuous, it's pretty safe.
Arthur, could you comment a little bit, because you mentioned this on one of your last slides. You know, obviously in the US, people are choose between RNS, which in this type of situation, most people would put probably a unilateral hippocampal depth electrode, and with the second electrode either in AN or else a subtemporal strip. I think there's some variability of that. But in terms of DBS, you know, hippocampal DBS is not FDA approved. So if people are doing it in the US, it's an off-label use. You know, it's one of those unusual things, but you showed that your patient outcomes are better with hippocampal DBS than they are with AN DBS. Can you comment on that?
First, the first issue is that when you do ANT-DBS, you're doing cycling. So it's different from continuous. I don't think we have any direct comparison data to say that one is better than the other, except that in the published series, it appears that direct hippocampal stimulation has a better outcome regarding seizures than indirect hippocampal stimulation by stimulating the ANT, which would make a kind of sense to me. The problem with not being able to do it is a kind of is very difficult to understand, because you can stick an RNS electrode in the hippocampus and you cannot stick a DBS electrode in the hippocampus. So it's I think you might be interested in the amount of stimulation during RNS is much lower than when you do continuous DBS, and that's for sure. And that's in my question here is if we know what we are doing, because if you think that neuromodulation is aborting ongoing seizures, you're going in one direction. If you think neuromodulation is modulating the interictal state and preventing seizures, then you're gonna go to another direction. If you look into the RNS recordings, it's not 100%, but most of the recordings of RNS activating during a seizure, the seizure will just go on as usual. It's very unusual for you to be able to clearly and regularly and consistently abort seizures by using RNS. Probably RNS is also modulating the interictal space. So
Can you unshare your screen just so we can see you?
Yeah, sure.
So
let me just show the outcome then before doing that. So
yeah, sorry.
So this was the programming. This was the programming for this patient. We initially used, I guess you saw that here. If you pay attention to this X-ray, there are two leads in tandem. We initially used the 391 electrode from Medtronic, but this was discontinued. So now we use two electrodes in tandem. So one is covered the head and the anterior body, and the other the body. This is the way we're doing. That's why you have programming for the anterior lead and the posterior lead. And you see it's continuous and it's high frequency. And bipolar, and of course this is not the outcome for every patient, but 30% of those patients, at least in our series, became seizure free, and he was luckily one of the patients that got seizure free. So
Arthur, can you talk a little more about how you're targeting that posterior lead, where exactly you're putting it?
Yeah, that's interesting, right? How to do it. It's what we do is you insert the first one, and then you measure the presumed position, the posterior position of this first one, and you target this position with the second one. And you can think that there gonna be a fight between the two cables or the electrodes, but surprisingly, they land perfectly one after the other. You don't even have to modify your entry point by a millimeter. You just do it, and somehow they accommodate, and they stay like this. It's very, they're very in line, let's say.
So if you unshare your screen here,
Yeah.
maybe Carrie, you could comment, and then John, you could comment as people who are practicing in the US about how you choose between RNS versus thalamic DBS or consideration of hippocampal DBS in a patient like this with unilateral mesial onset? Say we've determined that he is too high functioning to do anything that's going to be destructive. So how are you deciding RNS versus DBS, and what are you basing it on?
For us, it's very dependent on sort of my neurologists. And at the hospital I'm at now, my neurologists really love RNS. They love all the data they get from it. They love being able to see the individual seizures and make lots of changes. So I have not done a hippocampal DBS, and we almost never do DBS. For epilepsy, we almost always do RNS. And for this, especially where you know where the onset is, I feel like it's sort of an ideal RNS candidate because you can put a depth right through the hippocampus, you can do a subtemporal strip, and then we'll usually do a backup in the thalamus, which isn't plugged in but is available for later if needed. But for this kind of patient, for our center, it would always be an RNS. We just don't do DBS significantly.
John?
Yeah, it's a couple of things. One is the form factor and whether the patient can cooperate with the neuromodulation strategy. RNS is obviously more intensive in terms of what you need the patient to do, especially if you're not with a pediatric population. You may be dependent on a patient who's willing to do that. So depending on how far away the patients live, how well they are cooperative with the strategy, whether they want a craniectomy in the head versus this more standard DBS in the chest, those are factors. Other factors, if we really are relying on the long-term monitoring to try to lateralize the epilepsy, that's probably our leading use of RNS, is people who look bilateral hippocampal during our SEG, but we're still holding out hope that with time, they may actually be 90, 95% or more really coming from one side in the real world on medications. And so that often plays into it. In situations where it's a clear-cut equipoise, my neurologists tend to be biased more towards the DBS because it's lower maintenance in terms of the programming. But that's just again, it's local neurology biases. My question is whether, I guess, with ANT DBS, first the question of whether is it as effective as hippocampal DBS? Obviously, it's very intriguing to see ART studies. Some of the complaints with ANT DBS is people still complain of neurocognitive decline. And also I point out, even though the Sante trial was cycling, and we often start these patients with cycling, if it's not working sufficiently, many neurologists will go to a continuous stimulation. So I think we have enough questions to pose, and we have equipoise as to whether we should be trying to do a randomized clinical trial of ANT versus hippocampal DBS in America with Medtronic sponsorship, because either way, it's their device, their company. But we don't know what's more effective in terms of seizure outcome in this specific type of patient. And we also don't know what's better for neurocognition. So I wonder if this isn't ready for another question that could be answered with a clinical trial.
Yeah, I think there's a third issue too, which we haven't commented on, which is psychiatric outcomes and depression in these patients, and there is some data that ANT patients don't do as well in terms of if they have baseline coexisting depression, which a lot of these patients have. And we also didn't talk about that. We've had a couple of patients who have been psychiatrically very, very much worsened by focal lesioning in the dominant temporal lobe, where they took not that big of a hit in terms of their neuropsychology, but their depression was much, much worse. And I think we don't have good ways to predict that right now. And so neuropsychiatric outcomes would be an important part of any, whether it's observational, studies across multiple centers or a trial. I think we have to make sure we're including that in these patients.
Yeah, 2 comments on that. There's a recent study from Aaron Bowe's group where they looked at a large data set from Iowa. And what they found was a disassociation between hippocampal resection or ablation for lesional epilepsy, improving mood, versus hippocampal. So I'm sorry, amygdala resection or ablation, improving mood, whereas hippocampal ablation or resection was more associated with increased or worsening mood. So there may be a disassociation in these structures, and yet most of the time we're addressing, if it's surgery, we're addressing both of them, which might lead, there's also probably lateralizing effects too. So there's more benefits to mood if you're addressing the right hippocampus or the right amygdala. There's also emerging PTSD work just published from Siddiqui et al. So the point is, it's probably complicated. There's disassociations, whether you're targeting amygdala, hippocampus, whether it's left versus right. There's a lot of unanswered questions. making this very hard to predict. I've literally had patients where you do an RF ablation and their mood and their PTSD are immediately ameliorated, and you do the opposite, you do it on the left, and in just a little amygdalotomy and the patient's anxiety goes through the roof. So there's a lot of these little anecdotes out there, and I think there's a lot more for us to figure out. And my other final point about ANT and RNS is the other bias is whether or not in the SEG we really found something that's hard to localize. We tend to be biased more towards the ANT, whereas something that's exquisitely hippocampal, we tend to be more biased towards the hippocampal RNS.
Can Arthur, for you and Carrie, so if you have a patient that you've done a bilateral implant and you find that they're predominantly unilateral, so obviously we've talked about you could then do a resection. What about in the situation there if you want to consider a laser ablation, and how are you doing that and modifying that in the setting of the hardware that you have inside of the brain?
So we haven't had one yet that's a good candidate for that. We're hoping to, and there's other papers that have shown it, but what we would probably end up having to do is, in order to get good quality MRI and be able to get good laser ablation, is we'd probably have to take out the generator temporarily in order to be able to get good MRI without the artifact from the generator. And then pull it back, do the ablation, and then put the generator back in.
We are very biased on not offering in any way resective or ablative procedures in the dominant temporal lobe with a normal MRI. We were more, let's say, free, accept some more freedom to the non-dominant MRI. Although, even though for those with the non-dominant normal MRI temporal lobe epilepsy, we are getting more and more anxious because we thought they were kind of free of side effects from resecting the non-dominant temporal lobe. But as a matter of fact, if you looked into the highly functioning patients, when you resect the non-dominant normal MRI hippocampus, they also get some issues there. So what I'm meaning is that we are going in direction of not offering resective or ablative procedures for sure in the dominant, and maybe in the near future even in the non-dominant people with really normal MRI. So even if we wouldn't do it in the dominant, because they can say, as I mentioned, just go ahead, but then they're gonna be your patients for years and decades, and then you're gonna hear the complaints on memory. And if the neuropsychology, because the other thing is when they are high functioning, neuropsychology can give you a not worsen evaluation, but they did get worsened because from a neuropsychological period function so high that even when they lose 20%, they are still high. But in their performance during their daily activities and at work, they really show some decline. So I'm not sure about the non-dominant ones. We are heading towards offering less and less resective too, but for the dominant, we are not going to be offering any resective or ablative procedures for those people.
So we have one final question from Dr. Ivanovic, Arthur, about hippocampal DBS. And the question was specifically, how often do you need to replace the IPG with a 4.5 milliamp current of hippocampal stim? And do you think there's a role for directional or sensing leads in this circumstance?
Well, that's a great question. Even if you don't use rechargeable, if you use a non-rechargeable, and if it is unilateral stimulation, this can go for 5 or 6 years with a non-rechargeable. And if you have bilateral hippocampal stimulation, in usually 3 years. But to be honest, it has been many, many years since we did not use the non-rechargeables. We use the rechargeables. Our patients are young and they'll definitely need IPG changes in the future. So we use rechargeables, and then you can expect like 18, 20 years for the rechargeables. So it's we just don't start with the non-rechargeable and then go to the rechargeable. We just start with the rechargeable. And the second question was
directional or sensing.
Oh, yeah. Okay. So that's an interesting question, because I don't if you first look into that, it doesn't, there will be no, let's say, usefulness in using directional electrodes, because what you'd like is to stimulate, the volume of stimulation should be big. It's not only the hippocampus. You're stimulating the perihippocampus. You're stimulating the mesial region. On the other hand, we use directions that, as you've seen in the X-ray, because sometimes, especially in the anterior lead, if you go higher and higher, you are going to recruit the capsule, the peduncle, and then would limit your increase in intensity for stimulation. And then if you have a directional electrode there, you can avoid recruiting the peduncle with this, and then you can stimulate more. But other than avoiding capsular activation and peduncle activation, I don't see at this point any usefulness in directional electrodes. You can do it with regular non-directional electrodes, except that if you run into the trouble of activating the peduncle with high intensity, you have no choice of how to proceed.
Great. So I think, that's a good stopping point. Obviously, thank you so much, Carrie and Arthur. I mean, there's so many questions that a conversation like this generates, and we've got lots of great options. And obviously, we don't have consensus because everybody's doing what their center most favors. And so I think it's incumbent upon us as an epilepsy community to at least be pooling data and even, as John's saying, designing studies so we can get more definitive answers as we go forward. But thank both of you guys for great talks and a great conversation.
Thank you for having us.
Thank you. I'll open the post-webinar meeting. Thank you.